I will briefly introduce you to the technology or the software that's behind the work that you'll be seeing today. And I'll first be talking about sort of what is the problem actually that we're trying to solve with perfusion imaging. Now that is, this is a dynamic movie that may not be so dynamic this morning. It's also quite early. But the task here is to find out how much oxygen does the brain actually have available. And of course, that's important in many diseases. So the classical or perfusion technologies, they create images of blood flow, so of the blood supply to the brain. With it comes also maps of cerebral blood volume. So how big is the density of blood vessels in each point in the image. And finally, a map of the mean transit time of blood. That's the two maps divided by one another, which tells how many seconds does it take for the blood to pass through the microcirculation in that particular point. So I call that the classical perfusion MRI. You see how it's all black and white images. And actually that classical perfusion imaging had an anniversary last week. It's something I worked on many years ago, and here you can see my lab book from June 8th, 1994. So this is another century and another millennium, ladies and gentlemen, where I wrote that here could be a way to do perfusion, and that actually turned out to work quite well. In the perfusion imaging we do today, we've been overlooking something. What we've been overlooking is that the transit time, that last map you saw before, means a lot. In the top image, you can see how the red color is kind of how big a portion of blood's oxygen content is still present in the vasculature. See, it's all red, so all oxygen is there when it comes in, but as it streams down the capillaries, it's gradually extracted. But you can probably imagine that the more capillaries you have, the more capillaries the blood can distribute across, and the more can actually be extracted. So the mean transit time determines how much time is available for the oxygen to be extracted in the tissue. So that is possibly the most important number at all, because once the blood has passed through, there's no longer time for the tissue cells to extract its oxygen. And you can see how Sune here has calculated what happens if there's an uneven distribution of blood across capillaries. You can see again, if blood flows are very high, the transit times are so short that cells cannot access its oxygen. And if you add that up across capillaries, as Sune did here, you can see that there's a higher oxygen extraction up here where the distribution is homogeneous than down here. So that means that we have a blood flow. That's what we thought determined oxygenation at all. But we also need to know that distribution to know how much can be taken up by the tissue. So that's the mean transit time, the one we've been measuring all the time. But what this shows is that we need another one, and we've dropped that the capillary transit time heterogeneity, so the standard deviation, the spread of these transit times. So that's one more parameter that we need to determine. So what we all overlooked, just so you remember that, tissue oxygen access is determined by CBF, as we used to believe, but it's also affected by transit time heterogeneity, so whether oxygen can actually be taken up by the tissue. That is very important in disease because in disease we think that tissue hypoxia and tissue injury is caused by ischemia, so low blood flow. What this shows is it can also be caused by disorganized capillary flows. And I've tried to illustrate this here. If there are small dents because of risk factors or disease in the capillaries, blood can no longer be homogeneously distributed across the capillary bed and essentially shunts through the microcirculation. And this is just one example of how disease affects capillaries. This is an ischemia. Ischemia kills parasites, the little cells around the capillaries, and close capillaries, and that causes shunting. So even though there may be, some residual blood flow, it may not be well distributed. So even though you normalize blood flow, if you don't normalize capillary flows as well, you won't have your oxygen extracted. So we need to know that additional parameter, CTH. And actually, Kim developed the method that can do now. See how everything is in color now? So here we see the classical, this is a patient who had a stenosis, vascular stenosis, and had it removed by stenting. And you can see up here how mean transit times are long in the hyperperfused tissue. CBV is high, so there's a reactive sort of dilation of the microcirculation, and it normalizes afterwards. So this extra parameter looks very much like this one. This is the important one. So what the modern perfusion software provides is what the software that many of you will have access to, classical parameters, mean transit time, also Tmax, as has been used a lot in stroke, is also in there. But then it includes what Kim discovered, namely these methods to determine that distribution. And it also calculates the ratio between the standard deviation and the mean transit time, because that's a parameter that tends to remain constant in the microvasculature. And I'll show you in a little while why that's important to be able to compare the two to each other, essentially. And then it includes Sune Jespersen's work, where we take that distribution of transit times and the mean transit time and calculate the oxygen extraction that results from that. So that is not a measurement of oxygen per se, but it's a calculation of biophysically how much of the oxygen can actually be extracted. And then it multiplies that by CBF to give you an estimate of what could, with this microcirculation, could CMR2 be. So what we're going to talk to you, or what we're going to hear about today, are new discoveries that have been made with this software. Because essentially this means that we have to rethink the injury mechanisms. Why is it that tissue dies after stroke? What causes various diseases? And I'll just, since I'm not on the program, I pushed in a few images of some of the things that we have been looking at. As you know, in stroke, we used to think that was the tissue injury there, the hypoxic tissue injury, was due to low blood flow alone. So there's a certain ischemic threshold. What this image shows is here are two stroke patients who have identical reductions in blood flow in the two different hemispheres. And you can see here that CTH map I showed you before. And here that ratio I talked about that should remain normal even though you change blood flow. You can see it doesn't in this patient. We ascribe that to collapse of capillaries. And what you can see out here is that tissue died, whereas all tissue out here survived nearly. So again, that shows that it's not true as we used to think, that it's the residual blood flow that determines outcome. This was a patients where CBF was not restored, so they could not receive recanalization. But just imagine whether this means that if we could actually restore capillary circulation by some pill that would maintain capillaries open during ischemia, could bring that brain to look like that brain, could this patient, so the other way around, could this patient's tissue actually have survived, even though we could not restore CBF, which is the current therapy, but simply by giving a pill that maintained open capillaries? That's some of the research we're, of course, doing now. Another example is that the first time we used KIM software to look at Alzheimer's patients, we found something very surprising. You probably know that Alzheimer's disease has the same risk factors as stroke, but it's ascribed to neurotoxic proteins in the tissue that we are trying to remove with some of the drugs that are coming out now. What this shows is that if you take normally aged patients and one with mild Alzheimer's disease or beginning to get Alzheimer's disease and one with severe Alzheimer's disease, you can see that this abnormal distribution of blood flow, which is quite extreme all across the brain here. So what this means is that we have probably overlooked that the cells in the brains of patients with Alzheimer's disease are in severe need of oxygen. So even though they, the disease is associated with amyloid, it seems that it's really, there's an underlying hypoxia that's very severe. We've looked more into that. Here you can see areas of the brain where CTH is higher in patients who have mild cognitive impairment, so they don't have Alzheimer's disease yet. You see that's all over the brain where we measured perfusion. And these were all amyloid, and amyloid positive, so meaning they have amyloid in their brains. Amyloid is a very powerful pericyte constrictor, so it means that it constricts capillaries. And so we think that you have capillary flow changes to begin with, and when amyloid comes up, that accelerates a lot. So again, that has some implications for how we should probably prevent and treat these patients in the future. My last image is actually one for Nadia, because I know she's interested in neurodegenerative diseases. We spoke at length yesterday. And what is interesting is that there are a lot of nuclei in the brain that actually control blood flows in capillaries across the brain. And all of those nuclei are affected by neurodegenerative diseases, whether it's Alzheimer's disease or Parkinson's disease. These are patients with a sleep disorder that usually leads to Parkinson's disease many years later. And what we found there was that they actually have profound changes in capillary blood flows and in blood flow at this point, maybe because their disease is starting to affect these deep nuclei. So I look very much forward to today to hear about discoveries people have made with the software, and also keeping in mind that what this means is that we are really rethinking or re-exploring the pathophysiology of many diseases, as illustrated by this tip of the iceberg we've been looking at so far. So we hope that there will be, we'll be able to develop new therapies ultimately that will target the microcirculation and provide new avenues to treat and prevent big neurological and psychiatric disorders.